This session, I'll be discussing cesarean section and vaginal birth after cesarean section. I'm Dr. Adegoke Adedokun Isaac. I'm a consultant obstetrician and gynecologist at the University of Medical Sciences Teaching Hospital, Ondo. Now, I'll take you through our learning objectives. We're going to define cesarean section. We'll discuss the epidemiology of cesarean section. We're going to classify cesarean section. We are going to describe the procedure of cesarean section, then the evolution of vaginal birth after cesarean section, the benefits of vaginal birth after cesarean section, and you will learn how to predict a successful vaginal birth after cesarean section. After now, cesarean section may be referred to as CS, while vaginal birth after cesarean section will be referred to as VBAC. Then I have a list of expectation of learners at the end of this lecture. You should be able to define cesarean section. You should be able to classify and state the indications for cesarean section. You should be able to describe the procedure of cesarean section and its complications. You should be able to discuss the evolution of VBAC. Then you shouldn't have difficulty selecting patients for VBAC after this lecture. And you should be aware of the controversies surrounding VBAC. So we start with cesarean section. So this is the outline. I'll take you through the introduction, epidemiology, indications, classification, pre-op preparation, up to the psychological aspects of cesarean section. Then we'll conclude. So now, by way of introduction, the term cesarean was derived from the Latin verb cedere, which means to cut. And in those days, children of such births were referred to as seasons. And one of the most performed surgical procedures in obstetrics is actually, cesarean section is actually one of the most performed surgical procedures in obstetrics. And the incidence varies across the globe. In the real sense of it, this is what the phrase cesarean section is a form of tautology, because cesarean means to cut, then section means to cut. So it may actually be preferable to use the term cesarean delivery or cesarean birth. So let me take you through the history of cesarean section. There's been so many myths surrounding the origin of cesarean section. Some workers will tell you that the birth of Julius Caesar in 100 BC, that's the origin, that's the name Caesar, that's the origin of the word cesarean. Some say it's from the Latin word cedere, as I mentioned earlier. Some will tell you that it's actually taken from Roman law, lex caesarea, in the 8th century BC. And the earliest report of an infant surviving following cesarean section was in 508 BC. That was the birth of Gorgias in Sicily. And in 1500, they recorded the first survivor of the mother and the infant. That's to tell us that the mortality, the perinatal and maternal mortality following cesarean section was very high in those days. So in 1581, Francois Rousset wrote and described 14 cesarean deliveries. But interestingly, he never saw any of these deliveries. And of course, the first report of uterine closure was recorded in 1769. That means the earlier ones, the uterus was not closed after the procedure. So you can know why the mortality rate was so high in those days. And the first lower uterine segment incision that most of us use these days was first described in 1786. And of course, the Diety Herta was introduced in 1846. Then Queen Victoria delivered Leopold in 1853 through cesarean section. And the anesthesia that was used that time was chloroform. So in 1876, Poro procedure was introduced. That's the first cesarean hysterectomy. And by 1882, the value of suturing the uterine wall with silver wire was highlighted by J. Marion Sims. Then, of course, our popular delay incision was introduced in 1922. And by 1928, penicillin was discovered by the great Alexander Fleming, and the mortality rate reduced, especially mortality rates due to infection, reduced drastically afterwards. So let's define cesarean section. So cesarean delivery is defined as the delivery of a fetus through surgical incisions made through the abdominal wall. And of course, that one can mean laparotomy. And the uterine wall, which may mean hysterotomy after the age of viability. That means cesarean delivery is actually a combination of laparotomy and hysterotomy. But there's an exclusion. The exclusion is the removal of the fetus in case of ruptured uterus, because you may not need to open the uterus. So epidemiology. The cesarean section rate varies between and within countries. The recommended rate as at 1993 was 6 to 8%. But we have seen a gradual increase in the rate of cesarean section, and we're going to talk more about that as we move on. In Britain, the rate was 12%. In the US, the rate was 24%. And in Ghana, it was 21% as at 2002. And the incidence rose to 32.2% in 2014 in the US. In Nigeria, 15 to 21%. The one recorded in Ibadan, 19.8%, and so on and so forth. So now, what are those factors responsible for this increase in the rate of cesarean section? Reduced parity. Many women today don't want to have many children because of education and civilization. Then increasing maternal age. Then increased use of electronic fetal monitoring. Then high incidence of cephalopelvic disproportion. Then low tolerance for risk or litigation. Also, for socioeconomic reasons, sometimes convenience of the physician, then repeat cesarean delivery. Then, of course, elective cesarean delivery in patients, in some selected or special patients like HIV patients. Then, patient's request, because now we are advocating patient autonomy. So, patient's request too has increased the rate of cesarean section. So, what are the indications for cesarean section? The indication can be absolute or relative. It can be recurrent or non-recurrent. It can be fetal, it can be maternal, and it can be a combination of the two. So, let's highlight some of the maternal indications for cesarean section. Severe preeclampsia with unfavorable cervix. Previous classical cesarean section, you don't want to take them through VBAC. Previous extensive uterine surgery like mammectomy because of the risk of uterine rupture. Obstructive pelvic tumors like fibroids. Previous third-degree perineal tear and repair. Then previous reconstructive vaginal surgery like vesicovaginal fistula and corporaphy, because you don't want a breakdown of the procedure to correct the defect. Then large vulvar condylomata, vulvar herpes simplex virus, cervical incompetence with abdominal sacrilege, because you don't want to deliver the woman through the vagina because there's sacrilege within the abdominal cavity. So what you have to do is to do a cesarean section. Then HIV infection with low CD4 count, then high viral titers to minimize the risk of transmission to the fetus through the mother. So what are the fetal indications for carrying out cesarean section? Fetal distress in the first stage of labor, abnormal presentations that persist after external cephalic version, transverse lie, oblique that will require cephalic version, but if these abnormalities persist, you may have to deliver the baby abdominally. Then face presentation in mental posterior position. Then multiple gestation with malpresentation of leading fetus. Fetal macrosomia, usually greater than 4.5 kilogram. Very low birth weight, usually less than 1.5 kilogram. Fetal abnormality like conjoint twins. Then, of course, if you have an acute emergency like cord prolapse, you want to bring out the baby as early as possible. So you will have to go through the true abdominal delivery, especially if the woman is remote from second stage of labor. So now, combination of fetal and maternal indications. When there's cephalopelvic disproportion, when there's failure to progress in labor, when there's abnormal placenta previa, regardless of the degree, you don't want to take them through vaginal delivery in safe obstetric practice. Then, placenta abruption with the baby alive. You want to bring out the baby as quickly as possible because the source of nutrition is no longer there. Then, absolute pelvic disproportion, or when there's contracted pelvis in the mother. So now, let's talk about the types of cesarean section. Based on timing, as I mentioned earlier, it may be divided into elective or emergency cesarean section. Then, based on cesarean urgency, we have graded it into 4. The first grade is grade 1, that is emergent, when there is immediate threat to life of mother or baby, that's grade 1. Then urgent, when there is distress, but this distress is not immediately life-threatening, that's grade 2. Then scheduled, that's when there is need for early delivery, but there's no distress, that's grade 3. Then elective, that's the one that can be done at a time to suit the patient and labor ward team. For example, if there's multiple gestation, so you can actually, high order of multiple gestation, you can actually fix a particular time for the mother and even for the family. So that's the typical elective cesarean section. So now, let's talk about types of uterine incision. The types of uterine incision actually will be based on the presentation of the fetus, the gestational age, the placenta location, then how developed the lower segment of the uterus is. And of course, broadly, it can be classified as transverse. That's low transverse, lower segment incision. That's on the uterus now. Then vertical, that's classical or upper uterine segment incision. Then low vertical, that's delay incision. The incision that you put in the lower segment, about 2/3 is in the lower uterine segment and about 1/3 is in the upper uterine segment. We're going to talk a little more about this as we move on. So now, let's talk about the preoperative preparation for cesarean section. Of course, you have to obtain the patient's consent. Then, for elective cases, the patient should fast at least 8 hours, intravenous line with fluid. Then, the Paxil volume should group and cross-match blood. Then, you should catheterize the woman. Then, the anesthetist should review. Then, the pediatricians too should review. So now, let's talk about surgical techniques for cesarean section. We're going to talk about skin incisions now. We have the midlines of umbilical or infraumbilical incision. This used to be one of the most popular incisions for cesarean section. But these days, many of us go for Farnell-Steel incision, which is the second one. Then Joe-Cohen incision is another incision that is useful. Later, we're going to talk about Smith-Gavladak cesarean section, and you will realize that what they employ is actually Joe-Cohen incision. Then Maillard incision, then Paramedian incision. So now, what informs our choice of skin incision? The indication for the cesarean section, presence of previous scar. Most of us, we still want to go through the whole scar for cosmetic reasons. Then necessity for a classical incision. Then, of course, the gestational age. So now, talking about skin incision, the minimum length that is expected so that you don't have difficulty bringing out the baby is 15 centimeter. And of course, you can crudely determine the length using Harley's forceps. The length of your Harley's forceps is actually 15 centimeter. Then, excision of previous scar is essential for better healing and, of course, for a good cosmetic result. So now, let's talk about midline subumbilical incision. It's actually the incision of choice in emergency situation. Then, if other operative procedures are to be combined, it may be better to do a midline subumbilical incision. Then, of course, the exposure of the abdominal and pelvic organs are better with this incision. Then it's less vascular. The bleeding is less when you use this. The only problem with this is that it's actually prone to incisional hernia. Then Farnestine incision was actually introduced in 1900, and it's widely used mainly because of its excellent cosmetic results. Then when you are operating an extremely obese patient, it's the incision of choice because it's actually the thinnest part. The incision is made at the thinnest part of the abdomen. Then it's actually made at a line delineating the pelvic group is about 2 to 3 centimeters above the pubic symphysis. So it actually takes longer to perform a Farnestine compared to midline subumbilical incision. Then blood loss is a little more. Then you may not have access to the upper part of the abdomen. Then there may be damage to ilioinguinal and iliohypogastric nerves. So let's talk about Joel Cohen incision. It was originally introduced in 1954. And of course, it can be used for cesarean section. What we do is that we make a straight transverse incision slightly higher than Farnestine, usually maybe about 4 cm above the symphysis pubis. Then the anterior rectus sheath is incised in the midline. Then you open the peritoneum bluntly in a transverse direction. It's associated with less postoperative febrile morbidity, and the duration of surgery is shorter. So let's talk about a similar incision, Maillard incision. It's also a transverse incision above the symphysis pubis, and it involves cutting the rectus sheath. Or it's also a transverse incision. It involves cutting the rectus sheath transversely and ligating the inferior epigastric artery to minimize bleeding, and it provides better access to the pelvis compared to Farnestine. So paramedian incision, we hardly make this incision. It's used if classical cesarean section is contemplated. Then 1/3 of its length is above the umbilicus and 2/3 of its length is below the umbilicus. So now the skin incision versus uterine site. Most of the time when the uterine site you want to use is lower segment, what you are going to use, the types of incision you're going to use will include Kerr, that's the low transverse incision, low vertical, that's DeLee, then U-shaped incision. But if you are contemplating upper segment incision, then you should consider J-shaped, inverted T, and of course, uterine segment incision. That's classical. So now, you have to assess the degree of uterine rotation before you make any incision on the uterus. And the degree of dextral rotation should be determined by noting the position of the round ligament. And of course, this is to prevent extension to the lateral uterine vessels. So we sometimes call this angle of sorrow. So now, let's talk about low uterine segment incision. The lower part of the anterior uterine wall, which is covered by the loose peritoneum, is the uterovesical sulcus or pouch. And it's easy to recognize this at surgery. You see the loose UV peritoneum, and you know that that's the region of the lower uterine segment. It's now accepted as a standard approach. It's actually less vascular than the upper part, and that's why bleeding is less and has less contractile tissue than the upper segment. So hemostasis is easily achieved when you use a low uterine segment incision, and healing occurs readily, and there's reduced contamination of the peritoneal cavity because it's low down. Then vaginal batata section in subsequent pregnancies is possible. Then there's less postoperative complications like paralytic ileus, peritonitis, adhesions. Then there's reduced risk of uterine rupture in subsequent pregnancies. Then risk of rupture when you use a low transverse incision is about 1%. When it's low vertical incision, it's about 1 to 7%. When it's inverted T, it's about 4 to 7%, which is similar to the risk of rupture when you do a classical incision. So now, let's talk about the low transverse incision on the uterus. It's also called Kerr incision. As I mentioned earlier, it's employed in about 95% of all cesarean sections nowadays. Then, of course, it was popularized by Kerr in 1926. There's less bladder dissection, less blood loss. Then you open the uterus about 2 to 3 centimeter length centrally. You don't cut through the entire length through which you are going to deliver the baby. So it's just 2 to 3 centimeter length centrally. Then the Golgi membranes should be left intact. Then you can cut now with bandage scissors. Then you insert your index finger to extend the incision laterally. And what your fingers will do is to push the uterine vessels to one side rather than cut them. And this definitely will minimize bleeding. Then the low vertical incision, that's the delay incision, is indicated when you have a poorly formed lower uterine segment in preterm delivery. It's very popular in some countries. And of course, one advantage is that you avoid uterine vessels bilaterally. And studies have shown that it's actually safe. And it's a very good alternative to Kerr's incision. The only problem or what discourages people from using it many times is the fact that it may require extensive bladder dissection, about 10 to 12 centimeters into the lower uterine segment. And there may be an unwanted extension to the bladder. So you may not want to use it because of that. So U-shaped incision indicated when there's impacted fetal head. And this is because the popular one, the common one, the Kerr incision, does not create enough space when the head is deeply engaged in the pelvis. And of course, a U-shaped incision with a broad base, with a convexity of the incision pointing upwards the pelvis will be a better alternative. So J-shaped incision is useful in shoulder impaction mistaken for a breech. Then inverted T, we hardly use this. And it's been found to be frequently associated with intraoperative complications and prolonged hospital stay. Classical incision. Now, the indications of classical incision: when safe delivery via the Kerr incision is impossible, then in cases of extreme prematurity, before the formation of the lower uterine segment, or when there's preterm breech presentation with ruptured membranes, then when there's transverse lie with the back down and ruptured membranes, with or without hand prolapse, then when you have large fibroids in the lower uterine segment, when there's cancer of the cervix, you can see when you don't have access to the lower uterine segment, then of course you may want to employ classical incision. Then when you know that you're going to carry out cesarean hysterectomy, so as a preliminary to cesarean hysterectomy, you can give your classical incision because uterus is going out after all. Then very thin previous classical scar, then dense addition in the lower uterine segment. Then some workers advocate its use for placenta previa. It's neither here nor there. So now, incisions in classical cesarean section. It's better to use midline infraumbilical incision. Some even advocate the use of paramedian incision, but most of us hardly use paramedian incision. Then the incision has to be about 10 centimeters long in the anterior surface of the uterus. Then it should be made as quickly as possible because of the risk of hemorrhage. And when the placenta is anterior, there may be more bleeding. Then the risk of cutting the baby, inadvertently cutting the baby, is greater compared to low segment incision. Then usually you may have to deliver the baby by breech. So now, what are the advantages of classical incision? There's rapid entry to the uterus, risk of lateral extension into the broad ligament, and of course the vessels is nil. Then there's easy entry into the uterus when there is fibroid in the lower uterine segment. So what are the disadvantages of classical incision? There's increased intraoperative loss, high risk of adhesion formation, in subsequent pregnancies, high risk of uterine rupture. Then, of course, you can't take the woman through, you may not want to take the woman through vaginal birth after cesarean section because the risk is enormous. So now, we've talked about incision on the skin. We've talked about incision on the uterus. Now, let's discuss delivery of the presenting part of the baby. So, when the incision in the lower uterine segment is complete, then we can insert our Doyen retractor. We can now remove our Doyen bladder retractor. Then the presenting part is delivered. So when it's cephalic presentation, you insert your hand below the head to disimpact from the pelvis. Then your assistant will apply sustained pressure at the fundus. That's fundal pressure. It has to be sustained. Then, of course, you can deliver the head through the incision. Then you clear the airways. We don't have to wait for the pediatrician to do this. The assistant can easily do that. Then, what you do is that you apply gentle horizontal traction with cupped fingers to deliver the head. Then the occiput is delivered anteriorly. Then you can, if the head is impacted, you can rotate the head manually to deliver in hospital anterior position. So when the head is deeply engaged, what you do is that you disimpact from below by a third assistant. And one of our teachers described this procedure clearly, and this is actually called the push procedure. There's another one that is called pull procedure. Then you can use 1/2 of Wrigley's forceps to disimpact the head from the pelvis. Then, of course, you can deliver breech or you can extract. Then, when the head is highly mobile at a repeat elective CS, fundal pressure can be employed and Wrigley forceps can be used to assist the baby. In fact, all of us should be conversant with the use of Wrigley forceps. It can be very helpful. So now, when there's Bandus ring, these are special conditions. When there's Bandus ring, maybe prolonged obstetric labor, it's safer to make your incision through the Bandus ring. Then you can give nitroglycerin to relax the uterus if the cesarean section is difficult. Then if there's anterior placenta previa, you can incise the anterior uterine wall, then insinuate your hand between the uterine wall and the placenta to reach the membranes. Then deliver the baby quickly. Then you can incise the placenta to deliver the baby quickly, but the problem is the risk of severe hemorrhage and the fetus may even exsanguinate. So now, if the presentation is breech, I told you that we are talking about the special conditions now. If the presentation is breech, the lower limbs are delivered. We often say that once you can get one of the lower limbs, is as good as the baby is as good as being out. So if presentation is breech, the lower limbs are delivered and then the breech is delivered. Then you deliver the arms, then deliver the head, make sure the head is well flexed. Then care should be taken to maintain flexion, maintain that flexion. Yes, it may be well flexed, but you still need to maintain the flexion of the head. Okay, when there's transverse slide now with the membranes intact, make effort to convert it to cephalic presentation. After converting to cephalic presentation, from experience, you discover that the head may still be floating. So it may be prudent for you to deliver through breech delivery to save some time. Then when there's transverse slide with with hand prolapse rather, breech delivery via classical cesarean section is advocated. So now, we deliver the baby. Let's talk about delivery of the placenta. You can deliver the placenta through cord traction, it can be delivered manually, then the placenta can even be expelled spontaneously. And it's been said that when the placenta is expelled spontaneously, blood loss is less. Then there's decreased fetal maternal hemorrhage. Then there's decreased risk of maternal isoimmunization in case of rhesus isoimmunization. So now, we have delivered the placenta. Let's talk about repair of the incision that we have made. We should make effort to reduce bleeding from uterine incision. Then we should select carefully the site of each stitch. And why should we do this? Because we should, as much as possible, avoid withdrawing the needle. And of course, what we must pay close attention is actually the angle. The two angles, must pay close attention to them. We must incorporate them in the suturing. So the lower uterine segment is traditionally repaired in two layers. The first layer is actually more important than the second layer. Is the continuous locking. That's the layer that will secure your hemostasis for you. Then the second layer is the imbricating layer. That's the layer that will bury the first layer. But some workers have said that a continuous locking single layer is actually optimal for uterine closure. And it's been said to be safe and prudent. And it provides the best anatomical result and a strong uterine scar. Then it reduces the risk of endometritis, decreases operating time, reduces the number of suture materials used, and there's no increased risk of dehiscence in subsequent pregnancies. So the reference is there. So now, repair of classical incision. Classical incision is repaired in three layers. First layer with interrupted sutures, second layer with continuous suture, and the third layer with continuous suture to approximate the edges of the uterine serosa. And of course, as I mentioned earlier, let's avoid unnecessary needle tracts so that we minimize bleeding through the tracts. Then again, repair of peritoneum. It's safe, it's prudent. In fact, it's very good to omit peritoneal closure. Why? There's reduced need for post-op analgesia, bowel function returns earlier. Then there's no increase in adhesion, infection, ileus, wound dehiscence, and incisional hernia as previously mentioned by some workers. Then now, let's talk about uterine exteriorization. I know many people exteriorize the uterus, but it is not recommended because it causes discomfort and vomiting due to traction, and has been shown to increase pain and nausea, and may actually cause venous and hair embolism. So, we have repaired the uterus. Now, let's talk about the anterior abdominal wall, repair of the anterior abdominal wall. The rectus fascia is repaired with either interrupted or continuous non-locking absorbable or non-absorbable sutures. And of course, we hardly use routine suction drain again. Then subcutaneous tissue is closed with interrupted sutures if the space is more than 2 centimeters. Then, of course, it's encouraged, it's prudent to close the campus fascia. So now, we move to the skin. Skin closure. The best cosmetic outcome you can get is when you close subcutaneous compared to a percutaneous closure. So when you use a non-absorbable suture, you have to remove as early as possible. So I mentioned that we're going to talk about Miss Gavladak method of cesarean delivery. And of course, Miss Gavladak is named after a hospital in Jerusalem, Israel. And the skin incision used is actually Joaquin in opening the abdomen. Then the parietal peritoneum is opened transversely. Lower uterine segment transverse incision is employed. Then single layer uterine closure. Viscera and parietal peritoneum are left open. Then a non-locking continuous closure of the fascia. Then few widely spaced skin stitches. And why Ms. Gavladak was advocated when it was introduced, it was actually the fact that it saved a lot of time, and people still use it these days so that you can minimize the length of time and even the resources that you use for cesarean section. So now let's talk about complications of cesarean section. Cesarean section is associated with a great deal of maternal morbidity and sometimes maternal mortality. So therefore, prophylactic measures must be introduced to reduce maternal morbidity and mortality. So now, the risk of death following cesarean section is at least twice the risk of vaginal delivery. And of course, the risk of of morbidity and mortality will depend largely on the indications for cesarean section and of course, the intraoperative complications. So the range of maternal mortality is 40 to 80 per 100,000 cases. In Sweden, it's said to be about 1 in 20,000 deliveries. In UCH, said to be about 6.9 per 1,000 deliveries. That was in 1977. Then in 1999, at another site in Nigeria, about 15 per 1,000 deliveries. Then at yet another site, 40 per 1,000 deliveries. So it's not without complications. So now, what are the risk factors for complications? Excessive speed. The young ones that are just learning or doing cesarean section should know that you don't have to be very fast, in quote, very in quote. So excessive speed has been shown to increase the risk of complications. Then, of course, lack of experience. When the gestational age is less than 32 weeks, then when the station of the vertex is low, then labor is advanced already. So the lower uterine segment may be so thin, so the risk of extension may be very high. Then when there's ruptured membranes preoperatively, there's increased risk of postoperative infection when the membranes are ruptured. Then when your surgical technique is faulty, especially when you don't pay close attention to hemostasis. So now, a list of complications here: hemorrhage, infections, it can be wound infections, urinary tract infections, even something as bad as necrotizing fasciitis, then genital sepsis, then thromboembolism, then there can be injury to internal organs, injury to the uterus itself, then the bladder, the ureters, the bowel. Then there may be nausea, there may be abdominal distension after the procedure. Then there may even be injury to the neonate in form of lacerations, fractures of the humerus, fracture of the femur. So now, let's talk about hemorrhage as a complication. It's a common intraoperative complication, and the average blood loss at cesarean section is expected to be less than 1,000 ml. That's 1 liter. So when it's greater than 1,000 ml, we often say that there's excessive bleeding. That's hemorrhage. And what are those factors associated with hemorrhage? When there's placenta previa, when there's previous postpartum hemorrhage, then when there's prolonged stage of labor, preeclampsia, chorioamnionitis, classical cesarean section, as I mentioned earlier, preterm cesarean section, when you give general anesthesia, and of course, a combination of any of this. So now, what are those preoperative precautions that you should take to avoid excessive bleeding? The surgeon has to be experienced. Then you should be able to determine the placenta the location of the placenta. Then you should group and cross-match 2 to 4 units of blood before you carry out cesarean section. Then you should consider autologous blood transfusion sometimes. Then surgery by trainees should be done under supervision. So now, what intraoperative precautions should we take? We should avoid wide lateral dissection of the bladder, and in advanced labor, the incision should not be too low. Then we should avoid the extension of uterine incision during delivery of the head. Then as much as possible, we should allow delivery of the head in hospital anterior position. Then we should, as much as possible, expect a spontaneous expulsion of the placenta. Then judicious use of oxytocin, rapid closure of the uterus. Then uterine massage. Then when there's placenta previa, there should be direct pressure over the bleeding surface using hot packs. Then figure of 8 stitches in placenta bed. You underrun the placenta bed. So when there's intractable hemorrhage, we can do uterine artery ligation, B-Lynch brace suturing, internal iliac artery ligation, hysterectomy, which can be subtotal or total. Then now, postoperative infection as a complication. The risk factors: prolonged rupture of membranes, multiple vaginal examinations, use of fetal scalp electrodes. Then, of course, if there is bacterial vaginosis, then urethral catheterizations, maternal obesity. Then when cesarean section is emergency, may not have enough room to prepare. So now, infectious morbidity. Wound infection is said to be about 0 to 24%. Then urinary tract infection about 1 to 34%. Febrile morbidity about 0 to 66%. Endometritis about 0 to 86%. Then necrotizing fasciitis about 1 in 10,000. So it's extremely rare. So now, what prophylaxis do we give against infections? We should avoid shaving of the skin, or as much as possible, avoid clippers. Then preoperative skin preparation, skin should be properly prepared. Then good surgical techniques. We should avoid manual removal of placenta. I mentioned this earlier. We should try as much as possible to close the campus fascia. Then there may be need to give prophylactic antibiotics. Then remove the urethral catheter as early as possible. Then there should be surveillance for possible wound infection. Then the theater staff should be limited. This will definitely avoid or minimize the risk of nosocomial infection. So now, thromboembolism as a complication. This one is an important cause of maternal morbidity and mortality. And of course, there should be risk assessment for possible thromboprophylaxis before the surgery is done. So now, injury to internal organs as a complication. It's been said that bladder injury may be as high as 0.3%, ureteric injury about 0.1%. Bowel injury is extremely rare. Then postoperative management, there's been good hydration, adequate analgesia, ambulate them as early as possible. Within 6 hours postoperatively, you can introduce feeding. Then discharge them as early as possible. So now, there is need for us to reduce cesarean section rates because of the advantages that vaginal birth has over cesarean section rates. And of course, ways by which we can reduce cesarean section rates will include stringent requirement for a second opinion, then objective criteria for the 4 most common indications for cesarean section, then a detailed review of all cesarean sections. Then, of course, you should know and work towards reducing your personal, individual cesarean section rate. So now, what strategies can we employ to reduce cesarean section rate? Your statistics must be accurate. Then you must allow VBAC, that's vaginal birth after cesarean section. Then you must attend to poor progress in labor. Then you have to focus on labor management. Your labor management has to focus on reducing primary cesarean section in primigravida. Then there must be certainty of diagnosis of fetal distress, because many times people make diagnosis of fetal distress and it's actually not fetal distress. Then you might have to modify use of conduction anesthesia. Then management of breech presentation at term. Then experienced obstetrician must be available for, as I said, twin delivery. So now, let's talk about psychological aspects of post-cesarean delivery. This is very common in our environment. Loss of idealized delivery, insults from peer groups, there may be mortality, body contours may be deformed, then interrupted relationships with baby and husband. Then, of course, the woman may be hungry, even at hospital workers. Then, of course, the sexual relationship with the husband is impaired, at least for that period. Then again, what should we do? We should give clear and information that is clear and realistic information. We should minimize as much as possible unnecessary separation between the baby and the mother and even our family. Then regional anesthesia should be employed. Then there's need for postnatal counseling. So by way of conclusion, cesarean delivery can be life-saving. Therefore, people in environments where there's unfounded aversion to cesarean section should be convinced about its importance and safety. Then again, efforts must also be made to avoid unnecessary cesarean section, as it is not without complications. Thank you. So we now move to vaginal birth after cesarean section.